Hello, the following cases were presented at the 35th meeting of the Ophthalmological Society of the West Indies, which took place in Trinidad and Tobago in July 2024. This session, titled Primary Angle Closure in the Caribbean, Debunking the Myths, was hosted by the Association of Caribbean Glaucoma Surgeons. The Association of Caribbean Glaucoma Surgeons was founded in 2018. Our logo depicts an optic nerve with an inferior notch. The lighthouse, commonly seen decorating our Caribbean shores, represents our commitment to shining the spotlight on glaucoma. The ACGS seeks to eliminate glaucoma blindness in the Caribbean through advocating for universal access to international standard glaucoma care, promotion of evidence-based practice, encouraging regional scientific research, and glaucoma education for patients and colleagues. My name is Desiree Murray, and I am the founding president of the ACGS. I'm supported by a dedicated team of glaucoma surgeons from Barbados, Guyana, Curacao, Suriname, Antigua, and the United States of America. Our first presenter is Dr. Kaiwa Clark. Dr. Clark is an ophthalmologist with a special interest in glaucoma. He graduated from the University of the West Indies St. Augustine campus with a Doctor of Medicine in Ophthalmology in 2021. He's a fellow of the Royal College of Ophthalmologists, London, the International Council of Ophthalmology, and a member of the Royal College of Surgeons of Edinburgh. Dr. Clark is passionate about advancing research and expertise in the field and is dedicated to making meaningful contributions as a young ophthalmologist. I should mention that a lot of the evidence that we will present in this symposium is taken from the American Academy of Ophthalmology Preferred Practice Pattern on Primary Angle Closure Disease and clinical guidelines issued on the management of angle closure glaucoma from the Royal College of Ophthalmologists. Dr. Clark.
Thank you, Dr. Murray. So today we'll be presenting on various cases and myths related to primary angle closure disease. And the first presentation is myth number one. Primary angle closure is uncommon in the Caribbean. And in this, we will present a case of primary angle closure glaucoma misdiagnosed as open angle glaucoma. And we'll go into the epidemiology, diagnosis, and management of primary angle closure. Next slide. We'll start with a case, which is a 63-year-old Afro-Caribbean male who presented to us with painless worsening of vision to the right eye over the period of 1 month. He had been diagnosed previously as primary open angle glaucoma 4 years prior, and despite starting treatment, he had lost the vision in the left eye. When he presented us, he was on Zalatan to both eyes, Glaucotensil TD to the left eye, and Alphagan to the left eye 3 times a day. He had no known chronic illnesses, no significant family history of glaucoma, trauma, or steroid use, and he never worn glasses in his life. Next slide. So on examination, his visual acuity at the time was counting fingers in the right eye and no light perception in the left. His presenting intraocular pressures, 36 in the right and 60 in the left, with a left exotropia. His cornea on the left side had mild microcystic edema, and both anterior chambers were shallow. Gonioscopy revealed Schaefer grading angles of 0 to 1, but they open to 3 with indentation. Few intermittent peripheral anterior synechiae and patchy pigment. But unfortunately, due to the view was hazy on the left, but from what we could tell, the angles were closed. He had a significant cataract in the right, significant nuclear sclerosis, and posterior subcapsular. And we could see, despite the view being slightly hazy, that his cup to disc ratio at the time was 0.8. Because we had also scheduled him for cataract surgery, we had done biometry, and it showed he had normal axial lengths with an axial length of 23.72, but a shallow anterior chamber depth. Next slide. So this patient was diagnosed with primary angle closure glaucoma, misdiagnosed as primary open angle glaucoma. Next slide. So primary angle closure glaucoma falls under a spectrum of disease. And then there's acute angle closure glaucoma, which can affect anybody with angle closure disease. So primary includes iridotrabecular contact in 2 or more quadrants. A suspect will have that contact as well as normal IOPs and no peripheral anterior synechiae. Persons who move on to primary angle closure disease, which is primary angle closure, which they would have either high intraocular pressures or peripheral anterior synechiae along with that iridotrabecular contact. And those persons who have glaucomatous optic neuropathy are classified as primary angle closure glaucoma. Next slide. So if we were to look at the geographic distribution of primary angle closure worldwide, and the source of this was the World Bank in 1994, we can actually see that the Caribbean and Latin America and sub-Saharan Africa account for the almost the smallest proportion of angle closure glaucoma cases. But we must note that India, which has a significant population, some of our multicultural islands such as Trinidad and Tobago, or countries such as Suriname and Guyana, does have a significant portion of the angle closure glaucoma global distribution. Next. So we don't have, despite having many national surveys in the Caribbean, including the Barbados Eye Study, the St. Lucia Eye Study, the Eye Study in Suriname, we don't have disaggregated data for glaucoma. So we can look to our nearest genetic counterparts, West Africa. So when we looked at this population-based prevalence survey and the types of glaucoma in Nigeria, primary angle closure glaucoma out of all the glaucoma accounted for 5.1%, which is quite significant. Next slide. Even in our neighboring Ghana, there was a small retrospective study done at a eye hospital, an eye clinic there, where electronic records were reviewed for all patients who had attended clinic with a clear first glaucomatous diagnosis, and this was done between 2021 and 2022. And gonioscopy was done to differentiate between primary open angle glaucoma and primary angle closure glaucoma. And of those subset of patients who were diagnosed with glaucoma, primary angle closure glaucoma in this study was reported as 36%, which is the highest yet reported in West or Sub-Saharan Africa, compared to what the norm was, which is around 6% to 15%, which is still quite high. Next slide. Again, because of multi-ethnic and multicultural societies in the Caribbean, such as Trinidad and Tobago, Guyana, Suriname, we must also look at the prevalence of angle closure disease in the Indian population. And we can actually see, based on this prevalence study of angle closure disease in a rural southern Indian population, the overall prevalence of angle closure disease was 1.58, and that includes both angle closure glaucoma and primary angle closure. But of note, persons who are primary angle closure suspects, which is not included in that angle closure disease prevalence, actually was as high as 6.27% of subjects, which is quite high. So we can probably extrapolate that in our multicultural societies, such as Trinidad, Guyana, and Suriname, the prevalence of angle closure disease may actually be higher. Next slide. So how do we diagnose primary angle closure disease and the spectrum of disease? Well, yes, we can look at the risk factors and we can do Van Herring, but really and truly, the most important part of the diagnosis and examination is gonioscopy. Gonioscopy, gonioscopy, gonioscopy. I cannot emphasize this enough. Next slide. So if gonioscopy should be able to help us determine why is it that we're not picking up angle closure as much as we should. Well, maybe it has something to do with the gonioscopy rates. In a paper submitted in 2003 in the US, when they were looking at patterns of care for patients with open angle glaucoma, what they noted is out of 395 reviewed notes, fewer than half of the patients had had gonioscopy during their initial evaluation, which could be a significant risk factor for missing patients with angle closure disease. Next slide. But even more recent, when we looked at potentially missed opportunities in the prevention of acute angle closure crisis, and this was in 2022, patients who had suffered an acute angle closure attack, less than a third of them had actually had gonioscopic evaluation, which means that low gonioscopy rates is still a problem today. Next slide. So how often should we be performing gonioscopy? Well, the primary angle, open angle glaucoma preferred practice patterns actually presents guidelines, and gonioscopy in high-risk patients should be performed every 6 to 12 months. And high-risk patients include patients with established angle closure glaucoma, patients who may have pigment dispersion syndrome, trauma, pseudoexfoliation syndrome, and in some places they classify family history as a significant risk factor, even in angle closure glaucoma. In low-risk patients, patients who don't have these risk factors, after initial examination gonioscopy, it should be repeated every 2 to 4 years. Next slide. So what else can we use to help us with these patients with angle closure? Outside of potentially offering these patients cataract surgery, biometry can actually give us an idea not only of their angle closure status, but also their risk of progression to primary angle closure disease. Next slide. So this particular study, which looked at the development of angle closure and associated risk factors in the hand and eye study in China, what they noted after 5-year follow-up for progression to angle closure disease, significant risk factor for progression was anterior chamber depth, a shallow anterior chamber depth. Next slide. UBM and anterior segment are also more good modalities to look at the angle configuration, but unfortunately, these are not dynamic tests, and gonioscopy is a dynamic, indentation gonioscopy is a dynamic test and can actually give us an idea of if angle closure is synechial or not. And this can have an impact on our management decisions. Next slide. So what are the possible treatment options once we have diagnosed patient with angle closure? Well, in the acute or initial presentation, there's dynamic gonioscopy. We can use any of our anti-glaucoma medications, systemic or topical. They're topical cholinergic agonists, hyperosmotic agents such as mannitol, and laser peripheral iridotomy after the acute attack has resolved, once the corneal edema resolves, or you may consider cataract or clear lens extraction after the acute attack has resolved. And argon laser iridoplasty has a role in patients with plateau iris configuration or cloudy corneas. But now in the patients who have ongoing chronic or what's considered primary angle closure glaucoma, they may be treated with topical drops as their open angle counterparts, but many of them respond to laser PIs or lens extraction, which we will talk about now. But if they don't, they do go down the algorithm of primary angle closure requiring filtration surgery or possibly MIGS. Next slide. So the two main modalities we're going to talk about here are laser PIs and clear lens or extraction or cataract surgery. So the ZAP study, or the Zhongshan Angle Closure Prevention Trial, was a randomized controlled trial where bilateral primary angle closure suspects aged 50 to 70 were enrolled in an ophthalmic center. These patients received laser peripheral iridotomy in one randomly selected eye, and the primary outcome was the incidence of primary angle closure disease, and that means the progression to PAC, or primary angle closure, or primary angle closure glaucoma. Next slide, please. So of the 889 treated and untreated eyes, we noted that the incidence of primary angle closure disease was almost double in those patients who had not undergone laser PI. But that incidence was actually quite low. So next slide. So the interpretation of that study was that because of the low incidence of angle closure disease, laser peripheral iridotomy had a modest, though significant, prophylactic effect of progression to primary angle closure disease. And in the view of the low incidence rate of those primary angle closure disease outcomes and no immediate threat to vision once having close follow-up, the benefit of prophylactic peripheral laser iridotomy is limited, and therefore widespread use for primary angle closure suspects is not recommended. What was also noted out of a secondary publication from that study is that when they looked at the 6-year follow-up for progression to primary angle closure disease, what the significant risk factors for progression were shown were narrow angle opening distance and iris curvature. And in actual fact, the gonioscopy score in this case was not a significant risk factor for progression. Next slide. Now we move on to the EAGLE study, where we're looking at early lens extraction for the treatment of primary angle closure glaucoma. And this was a multi-center randomized controlled trial, and that looked at compared the standard of care at the time, which was laser peripheral iridotomy, to clear lens extraction. And the inclusion criteria, the patients were over 50 years. They had to be newly diagnosed with primary angle closure with IOPs higher than 30 millimeters of mercury, or primary angle closure glaucoma. And patients with symptomatic cataract, advanced glaucoma, or previous acute angle closure attacks who had undergone previous laser surgery or ocular surgery were excluded. Next slide. So what they found in this study was that the mean health score between the two groups was actually higher in the clear lens extraction group. And when looking at intraocular pressure, the intraocular pressure was actually also lower in the clear lens extraction group. And when looking at cost effectiveness per quality adjusted life year, over time, clear lens extraction proved to be more cost effective. What must be noted though, that of the two arms, there was only one case of irreversible vision loss, and that actually was in the clear lens extraction group. Next slide. So their interpretation was that clear lens extraction showed greater efficacy and was more cost effective per quality adjusted life year gained than laser peripheral iridotomy, and should be considered as an option for first-line treatment for primary angle closure glaucoma with high IOPs greater than 30 millimeters of mercury in the 50 and older age group, or primary angle closure glaucoma. Next slide. So back to our case, the patient was initially continued their topical medications. We initiated acetazolamide Diamox tablets to both 250 milligrams BD. Pilocarpine was started in the left eye and urgent cataract surgery scheduled to the right eye. And after cataract surgery, the post-op IOPs in the right eye after stopping acetazolamide was 9 millimeters in the right, 14 millimeters in the left. Next slide. So, and as we can see in the pre-op and post-op pictures, there's a significant deepening of the anterior chamber. Patient actually had 20/25 vision unaided post-op. So this is an example, not necessarily of clear lens extraction, but lens extraction being an option for the treatment of primary angle closure glaucoma. and also an example of how it can be missed. So primary angle closure glaucoma is still a significant threat to sight in the Caribbean population. Low gonioscopy rates may contribute to misdiagnoses, and once diagnosed, laser peripheral iridotomy and cataract surgery are viable treatment strategies. Thank you.
That's excellent. Thank you, Dr. Clark, for that presentation. And the take-home message really is gonioscopy, 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 not just in high-risk patients, but in all patients at initial examination, and then repeated as recommended by the preferred practice pattern of the American Association of Academy of Ophthalmology. Our next speaker is Dr. Vachel Lucez. Dr. Lucez is a local graduate of the University of the West Indies, having attained his Bachelor of Medicine and Bachelor of Surgery degree in 2010. He then obtained his fellowship in ophthalmology with the Royal College of Physicians and Surgeons of Glasgow in 2019. With 13 years of experience in ophthalmology behind him, he's currently a registrar at the Port of Spain General Hospital in Trinidad, with an interest in vitreoretinal surgery. His appetite for continued growth as a young ophthalmologist is fueled by his desire to make a positive impact on eye care in Trinidad and Tobago. Dr. Lucez will talk to us on simple microphthalmos and the myth that it is hard to miss.
Thank you, Dr. Murray. So I'll be presenting the second myth of this presentation, a case of microphthalmos and bilateral angle closure. This is a 56-year-old male with mixed ethnicity who had been referred from another tertiary eye care facility, with the right eye being known to have advanced glaucoma, uncontrolled intraocular pressure despite maximum medical treatment, and the left eye having a history of a central retinal fusion with subsequent neovascular glaucoma. She presented to us with a 6-week history of dimming of vision, right eye pains associated with headaches. This blurry vision has caused frequent accidental head trauma for this patient. She has no other significant ocular medical family history. It see her initial vital signs with a diascan of 109, suggesting good diabetic control at the time and a good blood pressure and pulse on presentation. The current medications included glaucoma medications, topical, latanoprost, combination of dorzolamide and timolol, as well as monidine, and also pilocarpine for her right eye. The left eye was being treated with topical steroid as well as cyclopentolin, and she had been on 3 times a day acetazolamide, but was poorly compliant with this due to gastrointestinal side effects. Her initial examination showed that indeed she was blind in her left eye and had 2/60 vision in her right. This, her only seeing eye, had a very high intraocular pressure at 40 millimeters of mercury. She was also found to have cataracts in both eyes, and her only seeing eye, the right eye, having advanced optic nerve cupping with pallor. Gonioscopy of the 2 eyes showed narrow angles in both eyes, and with indentation, there was no opening of the angles in the left eye, suggesting synovial angle closure, whereas at least 2 quadrants were able to open on indentation gonioscopy of the right eye, suggesting predominantly appositional angle closure. Her B-scan ultrasound of the blind left eye showed here tractional retinal detachment in that eye. So biometry was part of her early workup, which showed interesting findings, particularly if we focus on the axial length and her anterior chamber depth. If we reference the normal values for an adult shown here, you can see that axial length and anterior chamber depths were quite reduced outside of the normal. So her diagnosis at this point was simple microphthalmos of both eyes, primary angle closure glaucoma of the right eye, which also had a cataract, and the left eye having vascular secondary to central retinal occlusion, as well as a tractional retinal detachment. So her management, at this point, she was offered emergency right phaco emulsification with lens implant and dialysis. Her acetazolamide was continued subsequent to this, and much of her topical treatment for both eyes was continued as prior to surgery. At 1 month post-op, you can see that she has similar visual acuity in her right eye, unaided, 3/60, but of note, her intraocular pressure is significantly better controlled than it was at the time of presentation to us at 16 millimeters of mercury. So in summary, this patient was found to have bilateral simple microphthalmos in addition to bilateral angle closure glaucoma, as well as the history of neurovascular glaucoma secondary to retinal occlusion in the left eye. She has been treated with cataract surgery as discussed and is currently awaiting filtration surgery. So angle closure glaucoma refers to anatomic configuration in which there is mechanical blockage of trabecular meshwork by peripheral iris. Primary angle closure affects approximately 20 million persons globally, according to statistics from 2020, showing the rate of this disease globally. The risk factors for angle closure are listed here, most of which we would be familiar with, perhaps with the exception of ocular biometrics, which we want to focus on in this presentation. So ocular biometry, in eyes with primary angle closure spectrum, they tend to have a small, crowded anterior segment, as well as short axial length. The predisposing factors for an eye to developing angle closure are shallow anterior chamber, a thick lens, increased anterior curve, a short axial length, small corneal diameter, and a small radius of corneal curvature. As we could tell, a lot of these parameters can be easily identified on routine ocular biometry. Studies have shown that if the anterior chamber depth is less than 2.5 millimeters, there is a higher chance of that individual having primary angle closure. Conversely, those patients who have primary angle closure will have an anterior chamber depth less than 2.1 millimeters, showing the close association between these factors. Microphthalmos itself is a developmental disorder of the eye characterized by an axial length at least 2 standard deviations below the age. In the context of adult eyes, this usually translates to an axial length less than 21 meters. The prevalence of this condition is as high as 19 per 10,000. The inheritance of simple microphthalmos is usually sporadic, but can also be autosomal dominant, and other patterns of inheritance can also be seen, but less commonly. The main mutations implicated in this condition are related to chromosome 11. Here, there is a further breakdown of how microphthalmos is classified. So when we refer to simple microphthalmos in our case, it's a global reduction of all the parameters of the eye, including a short axial length, but with no other findings, whereas complex microphthalmos is simple microphthalmos associated with additional ocular malformations. There is also relative anterior microphthalmos and posterior microphthalmos, where have a reduction in the dimensions of the anterior segment or the posterior segment, respectively, in spite of having normal dimensions of the other part of the eye. So glaucoma is frequently observed in patients with anterior segment dysgenesis, which includes microcornea and microphthalmos. Approximately 50% of patients with anterior segment dysgenesis will eventually develop quite high. Microphthalmos, which is always accompanied with microcornea, is considered a primary risk factor for angle closure. Of interest with our case as well is the association or potential link between primary angle closure disease and retinal vein occlusions. There is, in fact, a study from India which shows that on analysis of the 600 patients with retinal vein occlusions, gonioscopy assessment of these patients showed 40% having previously undiagnosed narrow angles or closed angles on gonioscopy assessment. So this not only implies an association, but also a postulated positive effect, where primary angle closure could be an independent risk factor for retinal vein occlusions. So the take-home points here from our case are that microphthalmic children grow up to become microphthalmic adults. We must remember microphthalmos is not something we see in children. In microphthalmic adults, it is often only diagnosed when biometry is done for cataract surgery, and it will often not be picked up on a slit lamp examination. The risk of progression to angle closure can be better predicted by looking at ocular biometry as well as other factors, rather than with gonioscopy alone. Primary angle closure disease is also associated with retinal vein occlusions, and we must remember this may also be a positive association. And finally, routine biometry should be considered in all patients with angle closure disease. Thank you.
Thank you, Dr. Lusas, for that very interesting case and that important reminder that biometry is also an important part of the evaluation of patients with microphthalmos and angle closure. The next case will be, or the next myth rather, will be presented by Dr. Kaiwa Clark, and we would like to thank Dr. Janine Ramsahai for helping to prepare the previous case, and Dr. Vandana Prasad for assisting with this case. Dr. Ramsahai and Dr. Prasad are currently trainees in the postgraduate program in ophthalmology at the University of the West Indies. Dr. Clark?
Okay, so back to me and myth 3. And this will be a short case highlighting bilateral acute angle closure. So the myth is acute angle closure glaucoma is always unilateral, which obviously, based on our title, it is not. Next slide. So we're going to start with the case, which was a 67-year-old female who presented with sudden ocular pain, decreased vision, and redness to both eyes for 3 days. She had been diagnosed elsewhere at another ophthalmic institution with bilateral acute angle closure glaucoma with pressures in the right and left respectively 38 and 35. She had been started on fixed combination brimonidine timolol, dorzolamide, Predfort, pilocarpine, and Diamox or acetazolamide 250 milligrams PO 3 times a day by the referring ophthalmologist and was referred to the Port of Spain General Hospital as an emergency. Next slide. She didn't have any significant past ocular history other than she had been followed up at that other eye care facility, and as she had been already evaluated, examined, and was actually on waiting list for cataract surgery. In terms of her past medical history, she was hypertensive and had high cholesterol and gastroesophageal reflux disease, and was maintained on nifedipine and Simlo. And she smoked cigarettes and she also drank alcohol, but no other significant history was presented. Next. So when we examined her, she was counting fingers vision in both eyes. Because her acute event had already been treated, her IOPs at our presentation were 12 millimeters of mercury in the both eyes. She had normal lids, but of note, bilateral stromal corneal edema, and anterior chambers were shallow with Van Herrick's grade 1. Both pupils were fixed and mid-dilated, and there was no view to do gonioscopy due to the corneal edema. But of note, both lenses had significant nuclear sclerosis and glaucom flecking, all of which indicate a history of having very high acute pressures, probably related to her angle closure. Next. So what was done? So she had been diagnosed as bilateral acute angle closure glaucoma, and she had passed the acute event. The management had pilocarpine, Decombigant, dorzolamide, and Diamox were continued. Muro was prescribed to try to treat the corneal edema, and she was booked for urgent bilateral delayed cataract surgery. Delayed sequential. So because she was having cataract surgery and she had narrow angles, biometries were done. And of note, we can see here that she had on the lower limit of normal axial lengths, 22.42 and 22.47. Her horizontal corneal diameters were also borderline, 11, 10, and small in the left, 10. And her anterior chamber depths were shallow, and actually quite shallow in the left, less than 2 millimeters. And her other parameters were essentially normal. Next slide. So based on what Dr. Lucis spoke about earlier in terms of the spectrum of the small eye, next slide. Based on her axial lengths and anterior chamber dimensions, she has what would be considered normal axial lengths, but small anterior chamber dimensions. So that would fall under the diagnosis of relative anterior microphthalmos. Next. So what we know about relative anterior microphthalmos, they have actually a few studies when they looked at these small eyes, particularly RAM or relative anterior microphthalmos and cataract surgery, and they have significant potential complications, one of which is malignant glaucoma. So in these patients, something must be considered to reduce the risk of this occurring, and there are a few options. Prophylactic iridozonular hyaloidectomies, vitrectomies, sclerostomies, posterior capsulorhexis, and endocyclophotocoagulation or mixed procedures such as goniosynucleolysis and goniotomies. And these can be done in conjunction with cataract surgery in all eyes with axial lengths less than 20 millimeters. And primary angle closure glaucoma, they are especially high risk of these post-op complications. And this was particularly relevant to this case, who we were planning to do cataract surgery in both eyes. Next slide. So she had a left phaco IOL goniosynecholosis and goniotomy with a prophylactic iridozonular hyaloidectomy. That was then followed 1 week later by the right eye. Next. So on post-op week 1, her visual acuities had significantly improved from counting fingers to now 636 in the right, 624 in the left, and the pressures had stabilized at 17 millimeters of mercury, and Diamox had been stopped. So she had been only on Vigamox, Muro, Acular, Predfor, and fixed combination brimonidine, timolol. And as we can see in the images, she has nice, clear media now and obvious peripheral iridotomies, which are the sites of the iridozonular hyaloidectomies. At this time, we were now able to view the fundus, and we noted that her cup to disc ratios were still normal. But she did still have some persistent corneal edema, which accounted for her visual acuities. Next. And then in her most recent visit, which was June of 2024, the vision had subsequently improved, continued to improve. Vision was now 618 in both eyes, unaided. She had had bilateral eye laser capsulotomies, and the IOPs were 20 and 16 stable on Zalatan and fixed combination dorzolamide timolol. And as you can see here, everything was still pretty much in place. Next. So for this short case, the real take-home points are, and pretty much to emphasize what Lucis was and what was said in the first myth, gonioscopy is important. This patient had been sitting on a cataract waiting list for some time. She had already been evaluated, and it would have been quite likely if she had had gonioscopy, her risk of progression to primary angle closure disease and subsequent serious risk of acute angle closure would have been recognized. And also, all primary angle closure suspects should all have biometric data to rule out microphthalmos, as it has implications on the treatment, particularly if performing cataract surgery. Thank you.
Well, thank you for that very interesting case. And we'll move on to our fourth myth, which will be presented by Dr. Vachel Luces.
Thank you, Dr. Murray. Our fourth myth to debunk in this presentation is that laser peripheral iridotomy is a simple, risk-free procedure. Is it? First of all, what is a laser peripheral iridotomy, LPI? It's the laser to disruption of peripheral iris tissue to create a curved opening, which allows free flow of aqueous humor from the posterior chamber to the anterior chamber. This bypasses pill block, which is the most common mechanism implicated driving angle closure disease. So who needs this procedure? Obviously, the focus is on angle closure glaucoma, particularly, first of all, in acute angle closure glaucoma, as we saw with the case presented by Dr. Clark, where it's used to treat presenting eye, which often is one eye, but sometimes can be. But in cases where it's one eye, it's also used as prophylaxis for the fellow eye to protect from future attacks. It also has a role in primary angle closure suspects, and while the ZAP study as presented by Dr. Clark does not suggest that all patients as primary angle closure suspects need this procedure, there is still a role for it that should be judged on a case-by-case basis. Furthermore, LPIs have a role in the management of primary angle closure as well as primary angle closure glaucoma, while still acknowledging the facts or the findings of the EAGLE study, also presented by Dr. Clark, which suggests that in most cases, clear lens extractions will have superior outcomes. However, there can still be a role in some patients for LPIs. It can also be beneficial in patients with mild plateau iris configuration, as there may often still be a component of pill block in these cases. There is a big role for LPIs in the management of secondary angle closure glaucomas as well. For example, uveitic glaucoma with 360-degree posterior signage is the iris bombing. However, it may not have a beneficial role in synechial angle closure. It can be used to manage cases of subluxated natural lenses into the AC, which cause pupil block, capsular block syndrome, pseudophakic patients, aphakic pupil block associated with anterior chamber intraocular lens, as well as cases of iridoschisis with angle closure. So how is this done? The preparation for the procedure is important, which includes pre-laser acroconidine biomonitoring to help control or avoid post-procedure intraocular pressure spikes, pre-laser pilocarpine, which can be used to stretch the peripheral iris more to facilitate easier penetration by the laser. This procedure is generally done under topical anesthesia using a contact lens with a couple to the cornea. The aim is to target a site in the outer one-third of the iris, ideally within an iris crypt. These are some of the settings that are generally used for the YAG laser when doing the procedure, with an acknowledgement that different power settings can be used depending on if you have a thinner, lighter colored iris or thicker, darker colored iris. The aim is for the final iridotomy size to be 150 to 200 microns. There also must be an acknowledgement of the role of argon laser in this procedure. The approximate or commonly used settings are shown here for the argon laser, and it is particularly useful in thicker, darker colored irises, where it can supplement or precede the YAG laser procedure by first thinning out the iris stroma at the target site before using the YAG laser to penetrate the iris stroma. It should also be mentioned that some clinicians use the argon laser as the primary laser to do the entire procedure. Post-laser care involves most importantly checking intraocular pressure in that eye 1 to 2 hours after the procedure for the aforementioned spikes. Post-laser monitoring is recommended, and there can be an oral acetazolamide post-procedure in certain cases. Standard treatment thereafter is 1 week of topical steroids, usually at 4 times a day. And of course, peak gonioscopy is recommended 1 to 2 weeks after the procedure to reassess the angles and see what the effect of the laser has been. So all of this seems simple, right? But not so. Let's look at a few cases. Our first case is a 67-year-old Caucasian came with a 1-month history of glare, as well as seeing a line of light of his eyes. A month prior, he had been hospitalized with an accident and had a medical examination done, which included an ophthalmologist exam. There was an incidental finding here of narrow angles, but normal intraocular pressures and optic nerves, so he was diagnosed as primary angle pressure suspect. Bilateral LPIs were offered at this point, and they were done. Since this procedure, however, patient reports significant glare, sensitivity, and seeing this line of light in his field of vision. This has caused him difficulty driving during the day. He has no other ocular history of significance. Examination showed that he had quite good vision in both of his eyes, stable intraocular pressures in his eyes, and his gonioscopy showed open angles as showing potential effect of the PIs that he had done. You can see on examination here that he has superior PIs in both of his eyes. Retroillumination showed in this part of the iris in each eye. His posterior segment examination was unremarkable. So at this point, he was advised to use tinted lenses and has reported reduction in his glare with sunglasses, still sees these lines of light. So he has been experiencing dysphotopsias, which are known to be associated with LPIs. Question is, can we minimize them or avoid them altogether? Which leads to my next question. Does the position of where we do an LPI matter? And as it happens, there are studies that have sought to answer this question. The first is by Spaeth, US-based trial, 2005, where 93 patients were followed up after LPI procedures at least 1 month post-procedure. They were asked about dysphotopsia symptoms and were also examined on the slit lamp to check for the position of the LPI and the extent of the coverage of the LPI by the upper lid. The results showed that the lowest rate of new dysphotopsias were in patients who had fully covered LPIs by the upper lid. Surprisingly, perhaps, partially covered LPIs had a higher rate of dysphotopsias than fully exposed LPIs. The highest risk of glare was in these, as well as other dysphotopsias, and even monocular occurs when the LPI is partially covered by that margin. And the theory behind this is thought to be prismatic effect marginal tear film, tear strip, if it intersects with the LPI. Another study in 2014 based in Canada followed up 208 patients. Each had a superior LPI in one eye and a temporal LPI in the other. 169 of these patients completed follow-up 1 month after the procedure, and the results showed that superior LPIs by far had a higher rate of onset dysphotopsias at 10.7% compared to temporal LPIs, which only had 2% rate of dysphotopsias. So it was significantly lower risk of dysphotopsias with temporal LPI. A third study in 2018 based in India followed up 509 patients who were randomized to have superior LPI, nasal or temporal LPIs. Dysphotopsia symptoms were checked 2 weeks after the procedure in this particular study, and it's here showed significant difference of new onset dysphotopsias between 2 groups. Nevertheless, taking all 3 studies into account, weight of evidence suggests that PI position does in fact influence the rate of new onset dysphotopsia. So coming back to our patient, we can actually see that his upper lid margin is in close proximity to where his LPIs are in eyes, and it's likely that his tear film created the prismatic effect which worsened his dysphotopsias post-laser. Take-home points here are that LPI position does in fact affect the rate of new onset dysphotopsias. The lid position is critical, where the position of the upper lid margin relative to the superior limb should then be considered unchecked and LPI is performed. Overall, The evidence suggests that a temporal or nasal LPI are the safest bet to avoid onset dysphotopsias. However, superior LPIs can still be considered once the upper lid covers the superior limbus and superior iris adequately. So this decision depends on the indication's anatomy. Our second case here is a 52-year-old female of African descent who was referred to us for continued management after initially presenting 1 month prior with intraocular pressures of 58 times and Cup-to-Dis ratios of 0.9 times. She had been started at that point on latanoprost and brimonidine times. She has no other significant history. Examination showed visual acuity in both eyes and now stable intraocular pressures in both eyes as well. However, gonioscopy shows here she has narrow angles in both eyes, but no peripheral anterior synechial, so appositional angle pressure. Posterior segment findings are shown here in the advanced cupping of the optic nerves. So she was diagnosed as primary angle pressure low. Again, like our first patient, bilateral LPIs were offered and done, and she was started on routine topical steroids in thighs. At 1 week follow-up, she was found to have her LPIs were non-done. So that had to be treated at this time. 2 weeks following this, her intraocular pressures were significantly elevated, 25 millimeters of mercury. At this point, she was presumed to be a steroid responder. A quick taper of topical steroids was done, and her medical treatment of augmented combination timolol and dorzolamide eye drops, as well as acetazolamide at 250 grams TDS. A week later, the intraocular pressures were stabilized and her eyes were assessed in time. However, on further follow-up, she was found again to have severely elevated intraocular pressures, particularly in the right eye of 22 millimeters of in that. So at this point, she was no longer on topical steroids. So again, her acetazolamide was increased, and this was able to stabilize the intraocular pressures. But reassessment of her gonioscopy now showed that her angles were still quite closed in eyes, and now she had actually developed peripheral anterior synechial eyes, as well as pigment dispersion in her angles of eye. At this point, our patient was offered phacoemulsification of the right eye with intraocular lens implant and goniosynechialysis with goniotomy. She was initially unsure of proceeding, but eventually and has had good postoperative results in terms of intraocular pressures in the right eye, as shown here, now being stabilized. However, as time has passed, we could see an upward trend in intraocular pressures of the unoperated left eye, and indeed, acetazolamide had to be started to control the intraocular pressure of that eye. Take-home points from this case are that controlled intraocular pressures in our patient became recalcitrant high intraocular pressures after LPIs. This was likely caused by post-LPI pigment dispersion, as well as post-LPI inflammation to the development of peripheral anterior synechial, rather than the steroid response as initially thought. In retrospect, as suggested by the study presented by Dr. Clark, lens extraction through the lens implant was the better first-line treatment should have been offered to this patient. LPIs still have a role in select cases of angular disease, but the potential complications of this procedure should not be ignored. And those complications include high fevers, which are often transient, intraocular pressure spikes, as have been mentioned before, and are usually transient as well, anterior uveitis, which is usually controlled with laser topical steroids and rarely severe enough to cause posterior signs, corneal burns, iridotomy closure, as happened with our second case, which may then require a procedure either at the same site or new site level. Accelerated cataract formation is known to be associated with a peripheral iridotomies. Dysphotopsias, as we saw with our first case, occur at a rate of 6 to 12% with LPIs. And as must be mentioned, while aqueous misdirection is a rare complication with this procedure, it is a very serious one. It must be also in patients who hyperopic more than 6 diameter sphere, diopter sphere, with an axial length less than 21 millimeters. Of course, we should consider too, what are the contraindications to LPIs? Who should not get this procedure? Patients with an extremely shallow or flat anterior chamber, patients who have active untreated anterior uveitis, those who have a of the iris, most often unresolved, and particularly patients with extensive 100 degrees of peripheral anterior sign, because doing an LPI in this situation is a paradoxical rise of the jaw pressure, which can often be refractory to medical treatment. And of course, an uncooperative patient precludes a procedure such as this one. So in conclusion, we've shown today that a laser guide is not a simple, risk-free procedure. These are my references. Thank you.
Okay. Thank you so much to Dr. Clark and Dr. Luces, and to all the other members of the Association of Caribbean Glaucoma Surgeons. I'd also like to thank Dr. Vandana Prasad and Dr. Janine Ramsahai, who helped with the case presentations. And of course, we would like to thank the Ophthalmological Society of the West Indies for allowing us to present at their 35th annual meeting, and the University of the West Indies and their postgraduate training program. That brings us to the end of this session. The Association of Caribbean Glaucoma Surgeons, together we can end glaucoma blindness. Thank you very much.